Thank you for joining me. My name is Dr. Nancy Malek, and I'm a specialist anaesthetist in Australia. I've been working in consultation with Australian epidemiologist Dr. Kelly Jones to bring you COVID for Doctors Part 2. We believe that all doctors have a duty of care to learn about COVID. In this presentation, I'll be focusing on a structured appraisal of the recent peer-reviewed scientific literature, using a well-established epidemiological framework to answer a simple but critical question. Does COVID cause long-term harm? By harm, I mean adverse outcomes for both individuals and populations. And for simplicity, like in Part 1, I'll use the term COVID to mean the SARS-CoV-2 virus and the disease it causes. But before we begin, I'd like to tell you a story. This is the story of English epidemiologist Sir Austen Bradford Hill and the enduring legacies he left. In the 1940s and 50s, Bradford Hill and Sir Richard Dole were among the first to show convincingly that smoking causes lung cancer. At the time, this was radical, because smoking wasn't considered harmful. It was considered normal, even healthy. People smoked everywhere. Doctors smoked. Some doctors even prescribed cigarettes to their patients. A morning smoker's cough was considered to clear the lungs. Hill and Dole's work helped shift the narrative from accepted habit to recognised health hazard, and it laid the foundation for the public health measures we now take for granted, such as warning labels, smoke-free laws, and public education campaigns. And so we come to the second part of Hill's legacy. In 1965, he set out a framework for assessing whether an observed association is likely to be causal, now known as the Bradford Hill Criteria for Causation. Randomized controlled trials are obviously unethical when it comes to harmful exposures like smoking, and the same applies to COVID. The criteria are strength of association, temporality, consistency, specificity, coherence, dose response, biological plausibility, analogy, and experiment. They're not strict rules. They're considerations that help us judge whether an association is likely to be causal. We still use this kind of causal reasoning in clinical medicine and public health, including in oncology, cardiology, metabolic health, and occupational medicine. We accept these examples because they reflect established evidence and logic. And sometimes it takes time for that logic to feel comfortable. So now, I'll use the Bradford Hill criteria in parallel to address two questions. Does smoking cause lung cancer? And does COVID cause long-term harm? I'll take each criterion in turn, first using smoking and lung cancer as the reference example, then apply the same framework to COVID. Let's begin. The first criterion is strength of association. A strong link between exposure and outcome suggests a higher likelihood of causality. For example, heavy smokers have a much higher risk of lung cancer. Does strength of association apply to COVID and long-term harm? Let's examine the evidence from two very large studies. In the first study, published in Nature Medicine in 2024, over 135,000 veterans who'd had COVID and over 5 million uninfected controls aged 45 to 75 were followed for 3 years to estimate risks of death and long COVID. The key findings were, in terms of mortality, the non-hospitalized patients had an elevated mortality risk in year 1, and the hospitalized patients had an elevated mortality risk that persisted for all 3 years. Before we look at sequelae, let me briefly explain the statistics. Incidence rate ratio of 1 means no difference in risk. Greater than 1 means higher risk in the exposed group. Less than 1 means lower risk in the exposed group. Here's a graphical representation of the results called a heat map. These heat maps show the incident risk ratios of post-acute COVID sequelae by symptom in the first, second, and third year after COVID. Non-hospitalized patients are shown above hospitalized. Let's look at some examples of sequelae in year 1. In those with COVID who were not hospitalized, atrial fibrillation, 32% more likely than controls. Heart failure, 26% more likely. Pulmonary embolism, twice as likely. Fatigue, 51% more likely. Headache, 24%. And shortness of breath, 83% more likely than controls. In the second study from 2025, a systematic review and meta-analysis of 97 million individuals, researchers found an association between COVID infection and new-onset autoimmune disease, specifically those related to vascular integrity and coagulation. The baseline incidence of autoimmune disease in the general population is low, so large numbers are required to demonstrate the true impact of a disease like COVID. This study quantified results in terms of hazard ratios. A hazard ratio compares the instantaneous event rate at any given time during follow-up. A hazard ratio of 1 means the event rate is the same in COVID and control groups. A hazard ratio of 2 means the event rate is doubled in the COVID group compared to controls. The greatest post-COVID increases were observed in antiphospholipid syndrome, which had a hazard ratio of 2.16, ANCA-associated vasculitis, hazard ratio 2.15, mixed connective tissue disease, hazard ratio 2.12, and immune thrombocytopenic purpura, hazard ratio 1.87. In other words, the risk of developing these specific autoimmune conditions after COVID was around twice as likely as the uninfected controls. Risk was higher after severe COVID infection and lower in vaccinated individuals. Although longer-term studies are required, this is a very important signal, and this study highlights that there is a need for surveillance for autoimmune sequelae after COVID infection. From these two very large studies, people who've had COVID are more likely to develop health problems than those who have not. For strength of association, do we see a strong signal for long-term harm post-COVID? Yes, a clear excess risk remains after infection. The second criterion is temporality. The exposure occurs before the outcome. If X causes Y, then X must occur first. This is the only essential criterion of the 9. For example, smoking occurs first, lung cancer develops later. Does temporality apply to COVID and long-term harm? Let's examine the evidence from 2 specifically designed studies. The first is the Biobank re-imaging study from 2022. This study demonstrates temporality at the individual level. It was a longitudinal study, meaning that all 785 participants had a brain MRI before the start of the COVID pandemic. Then the same participants were scanned again after testing positive for COVID and matched to uninfected controls who also had pre-pandemic baseline imaging. Changes detected were therefore associated with COVID, rather than pre-existing risk factors or baseline abnormalities. What were the findings? Increased grey matter loss in the parahippocampal gyrus and the orbitofrontal cortex, involved in information processing and memory, and impaired executive function on cognitive testing. Now let's look at temporality from a population perspective. This study from Nature Medicine in 2022 looked for a range of new-onset cardiovascular events up to 1 year after a COVID infection. There were over 5 million people in each of 2 important control groups: a historical control group from 2017 and a contemporary control group from 2020. The control groups were almost identical, indicating that the baseline characteristics of the population didn't change during the pandemic. By comparing over 153,000 subjects with COVID to both of these control groups, it follows that the detected cardiovascular outcomes are most consistent with the effects of COVID. What were the results? Within 1 year after COVID, stroke occurred at a 53% higher rate over time than in uninfected controls. Dysrhythmias occurred at a 69% higher rate. Inflammatory heart disease occurred at twice the rate. Ischemic heart disease occurred at a 66% higher rate. And thromboembolism occurred at 2.4 times the rate of uninfected controls. In other words, across follow-up, these cardiovascular sequelae were consistently higher after COVID than in both the historical and contemporary control groups. In two different study designs, the timeline is clear. COVID occurs before the long-term harm in both individuals and populations. For temporality, do we see measurable harmful outcomes after COVID? Yes, the outcomes follow the infection. The third criterion is consistency. The association is reproducible in different studies, different populations, different settings, and at different times, etc. For example, smoking is linked to lung cancer in numerous studies worldwide. Does consistency apply to COVID and long-term harm? Let's examine the evidence from pediatric data. Results have shown that long COVID symptoms in children and adolescents differ by age group. These are landmark studies published in the Journal of the American Medical Association in 2024 and JAMA Pediatrics in 2025. In short, long COVID symptoms in children of all ages are not what you'd expect. In under twos, trouble sleeping, poor appetite, stuffy nose, dry or wet cough. In 3 to 5-year-olds, daytime tiredness, low energy, dry cough. In 6 to 11-year-olds, trouble with memory or focusing, feeling dizzy, back or neck pain, headaches, trouble sleeping, stomach pain, nausea, vomiting, fear of specific things, refusing to go to school, itchy skin or rash. In 12 to 17-year-olds, trouble with memory or focusing, feeling dizzy, back or neck pain, headaches, change in smell or taste, body, muscle or joint pain, daytime tiredness, low energy, getting tired after walking. These symptoms sound nonspecific, but they're the result of large cohort studies comparing children with COVID to uninfected controls. In July 2025, JAMA Pediatrics released a patient information document which stated that up to 10 to 20% of children are affected by long COVID, and it has surpassed asthma as the most common chronic health problem in children. There's no cure for long COVID, but researchers are working hard to find treatments. This 2025 Recover study compared nearly 300,000 children and adolescents with COVID to over 900,000 uninfected age-matched controls. Across multiple cardiovascular outcomes assessed up to 6 months after infection, children with COVID had higher relative risks of post-acute complications, including chest pain, palpitations, and myocarditis. The next study was published in JAMA Medical News and Obstetrics and Gynecology in 2026. It examined the impact of maternal COVID infection on neurodevelopmental outcomes in children by age 3. 9.7% of non-exposed offspring received a neurodevelopmental diagnosis by age 3, compared to 16.3% of offspring exposed to COVID. After adjusting for confounders, that equates to an adjusted odds ratio of 1.29. That's almost a 30% increase. The largest effects were observed if COVID infection occurred in the 3rd trimester, which is a critical time for brain development, and in male offspring. The proposed mechanism is thought to be mediated by maternal immune activation, which may disrupt fetal brain development. These findings underscore the importance of avoiding COVID infection during pregnancy and the necessity of neurodevelopmental monitoring for children exposed to COVID in utero. From these studies, COVID is reproducibly associated with long-term harm in pediatric populations. Taken with the totality of the evidence from other criteria, consistency becomes even stronger. For consistency, is there a reproducible post-COVID signal for long-term harm? Yes, the signal repeats across studies and age groups. The fourth criterion is specificity. whereby the exposure is specifically linked to the outcome, a single cause for a single effect. For example, smoking leads to more than just lung cancer, so specificity does not apply. Does specificity apply to COVID and long-term harm? Let's examine the evidence from two neurology studies. The first study, from Nature Scientific Reports in 2025, looked at cognitive decline in long COVID using a combination of PET scan, EEG, and cognitive testing. 28 patients with subjective memory and concentration problems several months after a mild COVID infection were compared to healthy, age and sex-matched controls. PET scans showed significant hypometabolism in bilateral frontal, temporal and parietal lobes, and the left occipital lobe. EEG showed frontal, temporal and central slowing. These changes provide objective evidence for cognitive deficits after mild COVID, especially in frontal brain regions. The second study, from Cortex in 2025, found that 25 patients with a mean age of 32 who reported subjective cognitive deficits more than 2 months after a mild COVID infection had abnormal cognitive tests with delayed free recall, attention, memory, and visuospatial skills, and abnormal MRI findings. Structural MRI showed reduced grey matter concentrations in the left inferior temporal gyrus, and functional MRI showed altered connectivity in various networks. In other words, even mild COVID can result in significant, persistent cognitive impairment and structural brain changes. COVID is not specifically linked to any one outcome. The neurocognitive outcomes from these studies are just one example of long-term harm. Specificity. Is COVID linked to one single specific effect? No. Specificity is a weak criterion for complex exposures like COVID. Just like smoking, specificity does not apply. The fifth criterion is coherence. The association between exposure and outcome is consistent with established science. For example, the effects of smoking are consistent with existing knowledge of lung cancer development. Does coherence apply to COVID and long-term harm? We'll use the example of COVID's effect on the heart and blood vessels. From the Journal of Advanced Research in 2025, this study took cardiac biopsy tissue from 5 patients within 3 months of their COVID infection. Histology showed myocardial fibrosis and inflammatory cell infiltration, and electron microscopy showed mitochondrial swelling, vacuolation, and fragmentation. This study provides mechanistic evidence that COVID impairs cardiac myocyte mitochondria and gives a plausible mechanism for COVID-induced long-term cardiac sequelae, such as fatigue, chest pain, palpitations, arrhythmias, and heart failure. Looking at arteries. This is the Cartesian study from 2025. Researchers followed nearly 2,400 people in 18 countries aged 35 to 65. 49% were female. They compared people who'd never had COVID, people who'd had mild COVID, and people hospitalized or in the ICU because of COVID. 6 months after infection, arteries aged by 5 years after mild COVID, and by 10 years for ICU COVID. The highest vascular stiffness occurred in those with long COVID symptoms and women. This suggests that COVID impacts blood vessel health beyond the acute infection, especially in women. And looking at veins. This was a systematic review of 15 studies analysing the incidence of DVT in patients with COVID between 2020 and 2025. Researchers found a strong association between COVID and DVT. COVID generates all the components of Virchow's triad: endothelial damage, venous stasis, and hypercoagulability. From this systematic review, the rate of post-COVID DVT was up to 47.5%. We've looked at the impact on cardiac tissue, arteries, and veins to determine that the effects of COVID align with established science, without contradiction. Coherence. Are COVID's effects on the cardiovascular system consistent with established science? Yes, there are no major contradictions. The sixth criterion is dose response. Greater exposure is linked with greater harm. For example, heavy smokers have a higher risk of lung cancer. Does dose response apply to COVID and long-term harm? Let's look at the evidence from two large cohort studies. This study from the Lancet Regional Health in 2025 looked at over 2,500 confirmed COVID cases and found that there was a higher relative risk of long COVID if the acute COVID infection was severe, it was a COVID reinfection, or the person was unvaccinated at first infection. The long COVID prevalence from this study was 18.9%, and in children. This study from the Lancet Infectious Diseases in 2025 assessed the risk of long COVID following reinfection during Omicron. After propensity score matching, approximately 40,000 reinfected children were compared with matched controls, allowing assessment of outcomes after first versus second infection. Reinfection was associated with more than double the risk of a long COVID diagnosis, with higher risks observed across multiple organ systems. There was also an increased relative risk of secondary outcomes, such as heart disease, acute kidney injury, generalized pain, and dysautonomia, suggesting that reinfections contribute to cumulative harm. Together, these studies demonstrate a clear dose-response pattern. Greater exposure to COVID through more severe infection or reinfection is associated with greater long-term harm. Dose response. Does this apply to COVID and long-term harm? Yes. Risk rises with severity of infection and repeated COVID infections. The seventh criterion is biological plausibility, meaning that the association is biologically plausible based on current scientific understanding. For example, cigarette smoke contains proven carcinogens. Does biological plausibility apply to COVID and long-term harm? Let's examine the evidence for plausible mechanisms. This study used in vitro experiments to show that the human ACE2 receptor is a necessary receptor for COVID entry into human cells. This was already known from SARS-1 research. The COVID spike protein has a high affinity binding site for the ACE2 receptor. ACE2 receptors are expressed on multiple tissues, which supports the plausibility of COVID as a multi-system disease. X-ray crystallography has revealed atomic-level structural detail of the ACE2 receptor bound to COVID's receptor binding domain. From Nature Immunology in 2023, this review article summarizes evidence of viral persistence after COVID infection. Viral RNA, proteins, and replicating virus have been detected in multiple tissues up to over a year after acute infection, even when PCR testing is negative. Persistent viral material in tissues may contribute to ongoing tissue injury, immune dysregulation, microclot formation, reactivation of latent viruses, and microbiome disruption. Together, these findings provide a plausible biological mechanism for long-term multi-system effects after COVID. This 2025 Journal of Medical Virology study describes a plausible blood-based mechanism for long COVID, involving persistent microclots and overactive neutrophils. Compared with healthy controls, patients with long COVID had a nearly 20-fold higher microclot burden, with neutrophil extracellular traps or nets embedded within the microclots, suggesting that they both drive thromboinflammation. This represents an emerging area of biomarker research and requires validation in broader clinical settings. This landmark observational study analyzed lymphocyte subsets in over 40,000 individuals across pre-COVID, mass Omicron infection, and post-COVID periods. During the peak of infection, total lymphocyte and CD8 plus T cells dropped significantly compared to baseline levels, even after excluding ICU patients and patients with pre-existing immune dysfunction. Importantly, CD8 plus T cells remained 9.9% below baseline in the general population, and in patients with cardiovascular disease, total T lymphocytes were still over 70% below baseline for up to 20 months post-COVID. According to the authors, these findings redefine COVID as a condition of long-lasting immune compromise and have implications for population health in terms of opportunistic infections, the reactivation of latent viruses, autoimmunity, and chronic systemic and vascular inflammation, potentially contributing to long COVID symptoms. There is evidence for tissue entry, viral persistence, thromboinflammation, and immune dysregulation in the short and long term. Biological plausibility. Are there plausible mechanisms to explain the harm caused by COVID? Yes, multiple plausible mechanisms have been identified. The penultimate criterion is analogy. There are similarities with other established causal relationships. For example, analogous to smoking and lung cancer, there's sufficient evidence that asbestos exposure can cause mesothelioma. Does analogy apply to COVID and long-term harm? Let's look at evidence from other post-viral syndromes. These three sources collectively demonstrate that post-acute multi-system illness after a viral infection is a recognized phenomenon, not something unique to COVID. Viruses such as SARS-1, MERS, and influenza can trigger long-term sequelae, such as respiratory, neurological, and cardiovascular impairment. Mechanisms include persistent inflammation, immune dysregulation, and ongoing tissue injury. There are many other examples of viruses with sometimes debilitating or even fatal long-term sequelae. For example, varicella reactivates as shingles. Epstein-Barr virus is linked with multiple sclerosis. Polio can lead to post-polio syndrome. Measles can lead to subacute sclerosing panencephalitis. And HIV precedes AIDS. Post-viral syndromes are well recognized. Analogy. There are similarities with other established causal relationships. Does this apply to COVID and long-term harm? Yes. COVID fits this recognized pattern. The final criterion is experiment. Causation is more likely if interventions that reduce exposure also reduce incidence. For example, interventions such as smoking reduction or cessation lead to a lower incidence of lung cancer. Does experiment apply to COVID and long-term harm? Let's look at the evidence for N95 respirators, air cleaning, and vaccination. First, some studies on N95 respirator masks. This 2025 study examined the effectiveness of PPE at preventing COVID infection. None of the 181 healthcare workers in this study contracted COVID from the workplace, evidenced by PCR and serology testing. The participants followed an established PPE guideline, had respirator fit testing prior to any patient contact, regular education and training sessions, and compliance checking throughout the study. This study provides real-world evidence that PPE is effective, as long as there's consistency and compliance. This BMJ review summarizes evidence that masks and respirators reduce transmission, particularly because COVID can be spread asymptomatically. This is a 2024 narrative review and meta-analysis of over 100 published reviews and primary studies. 7 key findings, and here are the first 3. Number 1. There is strong and consistent evidence for airborne transmission of COVID and other respiratory pathogens. Number 2. Masks, if worn correctly and consistently, are effective in reducing transmission of respiratory diseases and show a dose-response effect. In other words, the more consistently they're worn, the greater the protection. Number 3. Respirators, meaning N95s or better, are significantly more effective than surgical or cloth masks. Here are 2 studies on the effectiveness of air purifiers and UV light disinfection. This 2025 study in the Journal of Aerosol Science detected COVID in the air and analysed the effect of air cleaners to reduce viral load in a COVID clinic and ICU. They found that HEPA air cleaners reduced air viral load by up to 98.1%. This 2025 study compared the efficacy of germicidal UV light to portable HEPA filtration in poorly ventilated clinical environments. Germicidal UV light is effective at inactivating both COVID and influenza A. All of these technologies are effective at mitigating airborne pathogens like COVID and improving air quality by increasing the equivalent number of air changes per hour in indoor spaces. Now let's examine the evidence for COVID vaccination. This 2025 systematic review and meta-analysis found that COVID vaccines may be moderately effective at preventing long COVID, and the effect may increase with the number of doses administered. Compared to being unvaccinated, vaccine efficacy for one dose was 19.1%, for 2 doses was 43.2%, and for 3 doses was 70% effective for preventing long COVID, when given prior to COVID infection. This study from the Lancet Child and Adolescent Health in 2025 compared the risks following COVID infection with those following COVID vaccination in more than 13 million children aged 5 to 18 years in the UK. Overall, adverse outcomes were more frequent and more persistent after COVID infection than after COVID vaccination. Among almost 4 million children with COVID, risks after infection were elevated for arterial thromboembolism, venous thromboembolism, thrombocytopenia, myocarditis, pericarditis, and inflammatory conditions. Although these risks declined over time, some outcomes remained elevated beyond 12 months. By contrast, vaccination was associated with a small, short-term increase in myocarditis or pericarditis within the first month after vaccination. In summary, the risk following vaccination is substantially lower than the risk following COVID infection. Lastly, this study calculated the lives and life years saved by COVID vaccination worldwide. 13.64 billion vaccination doses were administered between late 2020 and 2024. It is estimated that 2.5 million lives and almost 15 million life years were saved, corresponding to 1% of the global population. Mitigations such as N95 respirator masks, clean indoor air, and vaccination lead to a lower incidence of COVID and long-term harm. Experiment. Causation is more likely if interventions that reduce exposure also reduce incidence. Does this apply to COVID and long-term harm? Yes. Mitigations are effective at reducing infections and reinfections. So, we've examined the recent peer-reviewed scientific literature using the Bradford Hill framework. The evidence repeatedly shows that COVID is associated with significant long-term harm, adverse outcomes for individuals and populations. But if any doubt remains, Bradford Hill himself said this: "It would surely be wrong to deny that smoking causes lung cancer because some criteria are not fulfilled. What is involved is not the logical question of whether one thing causes another, but the pragmatic question of whether it makes sense to act." COVID continues to circulate, and reinfections remain common. The pragmatic action is to prevent infections and reinfections. N95 respirators in shared air, clean indoor air, and vaccination.